Welcome, everyone. Welcome, everyone. Can you hear me okay? Yeah. To the penultimate session of the summit. And I don't know about you, but I think it's been an excellent summit. Now, this summit, as it says here, is about pulmonary fibrosis patients. It's the voice of pulmonary fibrosis patients in Europe. And I'm hoping that today, during this session, we do hear some voices from patients. We hear them online and we hear them in the room. So I look forward to hearing some of your experiences during this session. So I'd like to introduce my guest speakers today, John Saltines. And John is a patient from Norway. He's deeply involved in the Norwegian LHL patient organisation with peer support and patient advocacy. He is also the president of the EU PFF. His diagnosis journey started in 2009. It was not concluded until 2018. The long diagnosis journey made John engage in patient support and advocacy so that no one else had such a long journey. And I hope we hear a little bit more about that today, and it opens some discussions. Dr. Nazia Chowdhury. Dr. Nazia Chowdhury, Senior Clinical Lecturer at Ulster University and respiratory consultant with expertise in lung fibrosis at Altnagelvin Hospital, which is in Northern Ireland. She's the secretary at the ERS, Idiopathic Interstitial Pneumonia Assembly and Irish Thoracic Societies, Ulster Thoracic Society, and chair of the British Thoracic Society, ILD. And she's also one of the nicest people you could ever wish to meet. And a friend, I would say. And finally, in the middle, that little lady there is my wife. When I first told her I was part of the planning for the summit here in Brussels, part of the group of people that organised this event, and I said to her at the time, would you like to come to Brussels and speak as a patient? And she said yes. At that time, her condition was much better than it is today, but I'm delighted that she, against all the obstacles, got herself here, and she will be speaking to you today. So please keep that conversation going with her as well. So my speakers, so we start. John Saltine I've introduced, my wife Una, and Dr. Nazia Chowdhury. Advocacy. So what we're looking here is shared decision making in pulmonary fibrosis. And I'm really splitting this up into three things. One is shared decision making. The next bit will be advocacy. I'm going to take a couple of questions when we go through this shared decision making. I want to try to get through advocacy. And finally, we'll talk about the gold standard of care. So it is a simple but uncomfortable truth. Pulmonary fibrosis is not only a disease of the lungs. In my opinion, it is a disease of many decisions. Decisions about treatment, decisions about quality of life, decisions about hope and uncertainty, decisions how people want to live their lives. So what I'm looking to do is, I'm saying to clinicians, patients, carers, etc., let's start moving from an expert-led care to a genuinely shared care. A shared care where patients, carers, and healthcare professionals become partners. Care decisions, they must be shared and not dictated. So there are variations throughout Europe in access to specialist care in regions and in countries. And the EUPF is trying to reach out to many of those. And I in particular would like to see a lot more shared decision making going on throughout Europe. So what is shared decision making? In my opinion, it's a collaborative process where the clinicians and the patients combine clinical evidence and patient values and personal preference to choose care together. I think it's, there's lots of patients in the room here that will have experienced many things. And I think one of the most difficult things is that relationship between when you first meet your medical professional, your consultant, your ILD nurse, whoever, You're already a very frightened person. You go into the room, and I think it's extremely important that the clinician establishes a relationship straight away, and a relationship that doesn't use jargon, that uses simplistic language that you understand, and ensures that you do understand when they say something, what it means and what it means to you. And it's also important that that first meeting, it's like any relationship, first meetings are extremely important and establish a relationship. Understanding one another and making sure, as I say, the patient fully understands what is being said to them. So start off in that way. So clinicians, as we know, have the knowledge of the disease and can give you options. The patient has the lived experience. There's not a clinician that knows what it's like to live with pulmonary fibrosis unless they actually have it. So don't assume that you know what the patient is going through. You don't. Unless you have pulmonary fibrosis, you don't understand. It's like any other disease. So, as I say, the patient, they have the lived experience. They have the goals, fears, priorities, etc. Learn from the patients, I would say, to clinicians as well. Carers, I'm a carer myself, and quite often you feel isolated even during a consultation because quite often nothing's discussed with you. Nobody asks you anything. But you really genuinely have something to offer. So let's bring the three together and work together. So I've just got a few questions, and hopefully this will open some discussion. My first question, I think I'll go to John, if you don't mind. And I read a little bit about your diagnosis, John, and the delay, etc. But how did you actually feel, John, whenever you sat down that first time and you got your diagnosis?
Can you repeat the question, Tom?
Yes, of course. It's there in front of you as well, John.
Thank you.
How did you feel when you received your diagnosis?
Can I go pre that a bit? Because as Tom told you, I started my journey in 2009 and it was not included until 2018. And in 2018, I felt part of the collaborative process. Obviously, in those 9 years leading up to, I did not. So basically, what I discovered with the two first pulmonologists that tried to diagnose me, I was not a part of that collaborative process at all, which made me make a decision where I said, okay, John, you need to take some responsibility here. Do not necessarily take everything that comes from the other side of the table without questioning it. So I learned a lot of that process. But to answer your question, when I received my diagnosis, it was a true conversation, and I felt well cared for and as a part of that collaborative process, but not before that.
Thanks, John. Una, can I just ask you the same question?
Can you hear me? Yeah. Well, when I went to see my consultant, and he told me I had pulmonary fibrosis, I knew I was going to be told that I was having I was diagnosed with pulmonary fibrosis simply because I had lost several members of my family to the disease, and just previously, 5 months before that, I had lost my sister to that disease, who had spent many hours with her. I did not feel I had pulmonary fibrosis. I felt like a normal person. I was very active, and I couldn't get my head round I had this disease. So when I went in to see the consultant, I had it in the back of my head. He would say to me, "I'm really sorry, we have made a mistake. You do not have pulmonary fibrosis." And that's what I wanted to hear. But I didn't hear that. And I had also a list of questions to ask him. And one of the questions were, will I be able to have a lung transplant? And he said, no. And he didn't give me any explanation to why I couldn't have one. I had heard of the antifibrotic drugs because my sister had been on them. And I said, could I have the antifibrotic drugs? And he said, no. I then asked about my children because I was so upset that I could maybe pass this disease on to my children. He did not have an answer for me. He did tell me a lot of good things, but I don't remember them. I just remember all the no's. He then said, would you like to go and meet the ILD nurse? And within 10 minutes, I was in Pat Gorman's office, who took the time and explained everything to me. When I entered her office, I was very upset, angry, confused, and actually hated the word pulmonary fibrosis. I didn't want nothing to do with it. And Pat took time to explain things to me, explained that I would be able to have antifibrotic drugs, but just not at the moment. And I left the office with hope for the future, and hope that I will be able to live better with the knowledge that I had received from her. And I'll never, ever forget what she done for me that day.
So if I just move on to Dr. Chowdhury, just listen to John and another doctor, you know, how does that resonate with you, with what they've had to say?
Well, obviously, the first thing I think of is how upset I feel for Una, obviously, to have to go through that. And with regards to, you know, the question that you're posing to me about the importance, I think Una just describes that in very plain language as how important it is to have compassion and care as a doctor when you see somebody for that first consultation, because it is such a shock, and to be mindful of that. And that's why I'm here as a doctor, to learn from you as patients and carers so that I can be a better doctor. You know, shared decision making is obviously extremely important. Having an idea of what your beliefs and values are, and what those questions that are so important to you, to be able to have the time to answer that. And just to reassure you, because I do work in the medical school, and so when I trained, I had no training in communication. Really, it was just what you learnt on the job. There was no formal training in how to break bad news, how to communicate bad news to patients. You learnt from experience. You learnt to see very good communicators and said, I'm going to take that. That's a really good way of communicating this information. And then you saw very bad communicators. I work in a medical school. Communication and compassion is at the core of the training that we give now. Our new doctors are coming out understanding that the first question they ask a patient is, what do you understand about this condition? Do you know why you're here? What can I help you with? The listening is more important than communicating. And so I think there is hope. Having now working in a medical school, I think our new doctors are much better equipped with the skills, and I hope you will see that difference in the future. It doesn't have any consolation for the experience you had, Una, but it just highlights the key importance of a specialist nurse. And I'm sure it's hard to hear for some of you who don't have access to a specialist nurse, but I think if anything EU PFF can do is to advocate that every patient should have a specialist nurse available to them.
Thank you to our speakers. Is there any questions online? No questions online. Any questions on the floor? Anyone at this moment would like to ask any questions of our speakers?
very salient, and I think the training in communication it particularly. And I just wanted to recall a session that we did at an ILFA summit a few years ago, was looking at communication from two viewpoints. And one was for patients to also understand how to manage a consultation. And there's a lot of work done by a former GP called Roger Neighbour around communication approaches, and I'd encourage both clinicians and patients to have a look at that work. Because I guess it's also, from a patient perspective, you never know where the clinician is in their day, and they may have just had a really difficult conversation with the previous patient. And that's not an excuse, but it's the reality. And sometimes the next patient ends up being rushed through in order to keep on time. So I think it's something that we have to really work together with to improve communications for both sides. But definitely training in medical school has improved a lot, and we need to emphasise that.
I'm just wondering as well if there's any other patients in the room. This is a patient summit. Is there any other patients in the room that like to share their experience and their feelings on their diagnosis? Eleni?
I'm very glad to hear this panel with all these co-patients and all these friends. And I fully understand that all patients we have pulmonary fibrosis don't fit in one size. I heard from John and his feelings from diagnosis. I heard from Una his experience, and my experience was different from all of you and from others. We have a lot of commons in the course of the journey. But when I was diagnosed with pulmonary fibrosis, it was very soon. I don't relate to have my diagnosis. Because I have my mother that I lost her before 9 years from my diagnosis, from the same disease. So it was more easy for clinicians to understand that I have this disease. And this what I was feeling, it was an overwhelming sadness about what is happening to me. No one told us that this disease is familial and could be something that I have to check for it. So it's a very crucial moment for your life, the diagnosis, and you have to understand that you have to give to yourself the time to mourn, to mourning about your losses, about to lose your health, but to find the strength to go on and to give to you and to your loved ones the opportunity to have you hear them strong and fighting for them and for your life too. Thank you.
Thanks, Eleni. So we just looked through why I believe that shared decision making is critical in managing pulmonary fibrosis. As we all know, that pulmonary fibrosis does have some unique challenges. There is an uncertain prognosis for patients. The significant symptom burden as well to manage. There's multiple treatment pathways, quality of life trade-offs, and timing of intervention does matter. So common decisions requiring shared decision making. So starting or changing antifibrotic therapy is something that certainly needs to be discussed at all levels and definitely with the patient. Oxygen therapy is a massive step. Anyone who is suffering from pulmonary fibrosis knows what I'm talking about. The fact that you have began the journey, and I see many patients. We hold a support group meeting every week on a Tuesday. And you can tell the patients that are sitting there are looking at others who are not, they are not on oxygen, who are wondering, am I next to be wearing oxygen? And worrying about what that brings. It's a massive step, you know, and everyone, including our clinicians, need to understand psychologically the impact that I see on people who go on to oxygen, who would quite often come on to a support group meeting and announce, I've just been put on oxygen, and don't even realize that half the audience or more are already on it because it's such a big deal to be given the oxygen. So they need a little bit of time. Pulmonary rehabilitation, I don't think there's a lot of decision making needs to be done there, but it certainly needs to be discussed. For me, there's just not enough pulmonary rehab going on. You have to be careful when you use that term. I know I've used the term rehab without putting the pulmonary in sometimes, and it does cause a bit of confusion. So clinical trial participation, certainly shared decision making there, and trying to get, letting patients know the advantages, the disadvantages of doing clinical trials and bring them onto it. Advanced care planning needs to be discussed. And we had a great talk this morning about palliative care. I really did enjoy that. And I think we need to talk about that a lot more. In my own country, when you use the term palliative care, it does have a cultural sort of thing. So I think we all have to get used to the term and use the term more often and feel more comfortable with it. My own country, you would feel if you hear that somebody has gone on to palliative care, tend to get, the rumors will go around, that's end of life, and it is, as we all know, it's not. So that needs to be explained, because you have to remember that a lot of the patients that come in, if you start using the term palliative care, they assume that that's end of life care. So you do need to make sure they understand. Just on those points, and just open to our speakers, what's your view, or your perspective on any of those that I've just covered there? Would you like me to go back?
I can start just
I'm
from a
talking about
healthcare
these
professional.
common decisions. They're just,
I think one of the things I will highlight is the complexity of the discussions, actually. And actually, I tend to gauge what I'm going to discuss based on the feedback I'm getting from the patient and carer as to how far I go, because there's so much to discuss. And I think we touched on that with the palliative care talk. You know, when do you start having the discussions about supportive care and palliative care, and particularly when it's an initial consultation, the focus really is about the diagnosis and starting treatment. And I think it's important then to see the patient fairly soon again and give that time to then address the other aspects. But often I'm gauged by the patient and carers, because often they might say, you know, like Una knew that I have family members and they needed oxygen. Do I need oxygen? And then that kind of is your buy-in to talk about oxygen at that time. But certainly, I mean, we are in a very unique position, I think. I've realised since being here, having our specialist nurses, as clinicians, we are very kind of time critical, I would say, and often it can feel rushed. And that's where the nurses come in, who have more time to go through things in a lot more detail. But I'm always overrun in my clinics, because I hope that I do give patients enough time that they need. And if I'm overrun by 20 minutes, that's just the nature of my pulmonary fibrosis clinic, is that I've got nowhere else to go after my clinic. So it's really important as healthcare professionals that we give our patients enough time to process all this information and ask the questions that they need answering.
what about yourself, John, on any of those particular points?
Yeah, I actually got several. want to move back to the diagnosis point as well. I wouldn't have been diagnosed if it wasn't for my wife. She's sitting in the back there. I want to bring out the carer perspective because I was obedient. I listened to the doctors, and the doctors said, John, your body's working as it's supposed to. You're coughing because your body wants to get rid of something. Little did I. So I went around for several years saying that the best in the country have stated that my body is working like it's supposed to. And my wife said after a couple of, I fainted, I broke my ribs, I coughed so hard I broke my ribs, I lost consciousness. And she said, John, it's not going to be like this. And I said, yes, they told me it's going to be like this. So she said, no, I won't accept it. So basically, the carer's perspective and the carer's role in the shared decision making as well. Because she is with me sometimes, and you've seen me, I'm a positive guy. Sometimes I may underreport, and she'll catch that, and my doctors know that now. So the triangle between the medical professional, the carers, and the patient, that is super important. And if I can just say, pulmonary rehabilitation, it's critical because there you can, I usually say, it's not dangerous to hit a brick wall, it's just very unpleasant. So if you do that when you're in rehab, pulmonary rehabilitation, it sounds much better. If you do that when you're in pulmonary rehabilitation, you know where your boundaries are, where your limitations are. So you need to come home and do exercise. You're not that scared. Because people who has not been at pulmonary rehabilitations, they do not know their limits. And many of them do not dare to try to push those limits as well. Does that make sense?
Yes, it does. What do you think, John, on the oxygen therapy? You know, because you will get patients that's prescribed oxygen, and they feel there's a psychological impact of being prescribed it, but also the awareness that other people could be seeing you physically wearing it, friends, family.
Yeah.
How did you feel whenever that was prescribed?
I usually say that if I open my mouth, you know the expression camel swallowing, camel swallowing we have in Norway?
Yeah.
That means, yeah. So I'm light brown on the inside from all the camel swallowing. That means, and I have a lot of friends in the audience here as well who is concerned for me right now because they said, John, you gotta wear your oxygen. It's out in the office there. I had it on the bus, but sometimes I tend to forget. I got activity oxygen. And it's a big discussion if activity oxygen is a real thing.
Yeah.
Because some doctors say, no, we're using LTOT or long-term oxygen therapy. That means that you will require 15 hours or more of oxygen. I don't that. But on the other side, for me to have activity oxygen, it's the difference between able to do exercise or not. So basically, those two are both critical, and medical societies need really to find out that obstructive patients like COPD patients and restrictive patients like pulmonary fibrosis are not the same when it comes to oxygen therapy. Too many physicians treat it as one and the same.
Yeah. And just on the antifibrotic therapy, I know you said earlier that you didn't get put on it straight away, but it was rules at that particular time that stopped you from going on to it. But you've been on it and taken off it. How do you feel the decisions and the discussions that you had about antifibrotics affected you?
Sorry, about being taken off?
No, just using them. And
Regarding antifibrotics for you,
For
when
me?
you started and stopping, how did you feel they
When I had the...
Your microphone.
Oh, sorry. When I got the discussion about going on to the antifibrotic drug, I was delighted because I thought it will prolong my life. And I didn't care about the side effects. I had researched it. I knew what was ahead of me. But just the fact, I thought, well, not everybody has the side effects. And I might be one of the lucky ones. So I went on, and I was quite happy to go on it. Unfortunately for me, it didn't work out I had problems right from the start. It was attacking my liver. I was very sick, diarrhea, and a lot of lost weight. So I was then taken off it last October, which I was very disappointed about. And when I asked, could I try the other drug, pirfenidone, I got the same answer, no, with no exclamation. And that, I was disappointed with that, very disappointed. I knew myself the reason why I didn't get it is because my lung function kept dropping. And I had been going every 3 months for lung function tests. And I knew that only happens because you have a problem. So it didn't surprise me, the no, but disappointed that I didn't get the conversation and the explanation that I wanted. But I did get it from my ILD nurse later on, as also. Would you like me to tell about my oxygen problem?
Yeah, yeah, of course.
Yeah. I had a problem while on oxygen. I'm
Sorry.
still on oxygen. But shortly after I started oxygen, I had a problem. And my problem was, in Northern Ireland, each patient orders their oxygen by telephone according to their prescription. It is provided in 3 ways: by a concentrator in your home, in cylinders, or a mother tank full of liquid oxygen. You then fill them up yourself. The cylinder and liquid oxygen was delivered to my home. The empty cylinders and mother tank are replaced with full. Historically, this had a problem whereby on the day of your delivery, on the day your delivery was due, a message would be received on your phone to tell you you were either, your delivery with driver was on his way to deliver and replace your oxygen, or you would not be, or you were told it was not being delivered because of the high demand of drivers. Because you would be almost out of oxygen at this point, it was very important that you got your delivery. My story is, I was left without oxygen for all of 5 days in July 2025. I took my complaint to the person responsible for health, the health minister. He was visiting our respite facility in August that year, and I told him in a presentation about the issues I and many others were having with our oxygen delivery. He assured me that he would investigate it and do something about it. He did nothing. In fact, he took the delivery company's side, saying that there was no problem. And as you can imagine, I was very annoyed. So I contacted the TV and radio stations, and very soon the story was on the national news. This got the health minister's attention. I was then contacted by the health board, procurement team, the statistic planning group. He then realised this lady was not going to go away until the situation was resolved, and that everyone in Northern Ireland got their oxygen in a timely manner. Very soon, the situation got some action. My voice was heard, an action plan was put in place with the delivery company. Additional drivers were employed to ensure that everyone got their oxygen as required. And I now sit on a committee to ensure that things do not slip back. I have told the committee that I would be, I told the committee who are responsible for the oxygen delivery that I would be their window to what is happening with deliveries and report to them how things are going on. This, I believe, is an excellent example of a powerful patient's voice that can be, and I hope will empower others to fight for their rights, no matter who tries to put them down or is not listening to you. Use everything you have within your power and the rights to fight for what you deserve. As many of you listening today will understand, it is difficult enough living with pulmonary fibrosis, but when your health is being ignored, that is totally unacceptable. There's a quote close to my heart, and that is, when the world is silent, even one voice becomes powerful. I believe there is no more powerful voice than the voice of the patient. Please use your patient voice to speak up and against any injustice within your treatment. Use every breath you have to speak up and speak out. And I thank you all from the bottom of my heart for listening.
Wimda, I think we have a question at the back, yes?
Yeah, thank you very much for your. This is very moving. The patient testimonies we have. I thank you very much for being so brave. Me as a healthcare professional, I'm a bit ashamed being here, but I can only echo Dr. Chaudhry's wise words that we are here to learn from you, and so. I also want to raise a point of discussion and to learn what is your opinion about it, because it is very fancy to use the term shared decision making. But that means that the patient is being given the right information. And this is crucial. And that also means that the necessary expertise should be there with the healthcare provider to provide objective information, especially for the initiation of drugs. It really pisses me off that there is many colleagues that, although they work in academic centers, and I think what John said is you think that you have the best doctors before you, that they are given the wrong advice. Why should you go on antifibrotic agents? They will make you sick. The benefit is not proven whatsoever. And then they say, we came to a shared decision that we will not initiate specific drugs, that we will not refer the patient to an expert center. And that feels very unfair, because as a patient, you're in a very difficult position. You can judge that probably there is only 10 channels on the television when you're admitted, that the food is very bad, but it's impossible as a patient to judge the quality of the advice you get. And so I think this is crucial, and I was wondering how you think about that and how we could work on that.
Well, first of all, I would like to just congratulate that comment. Thank you very much.
I'm going to say one thing, the power of patient organisations. I think as a patient, we've talked about being your own advocate, of not just, of questioning. And I think you have to question healthcare professionals. I think the historical nature where when you went to your doctor and they told you this is what you're going to do and you'd go away and do it has gone. and that actually that's the whole point of shared decision making. It's about the patient telling you their values and their beliefs so that you can come up with a joint plan. There are still doctors, as Wim says, out there who don't study that mantra, and it's up to patients and carers to question that. And if they don't know, you don't know what you don't know. I think that's a famous politician saying that, unfortunately. And so it's important then to reach out to your patient organisations, who are your advocates, saying this is the treatment you should have, these are all the decision points that you should have, and then you should be going back to that healthcare professional and questioning them. And if they are not treating you the way that you expect, then find somebody else.
So we're going to, sorry, John, just quickly, we'll need to move on.
No, I was just going to say, I absolutely agree. I usually tell patients that if you find a physician only using acronyms and you don't understand, say, please, this is important for me that I understand, and ask them again. And they still cannot explain to you in a way that you can understand. Find somebody who will be able to.
Okay, we've gone through that. So current gaps in care, well, we know there is delays in diagnosis. I think most of us will understand these. Unequal access to specialist ILD centres, poor communication about prognosis, limited holistic and supportive care, and variations in treatment access. I am going to go through the next couple of slides a wee bit quicker. So the power of advocacy. We've heard it, you know, a little bit ahead of cue, but we've heard the power of advocacy there. Very well put by my wife there, Una. And it really did have a major impact. We were having major problems with oxygen deliveries, and I know it varies throughout Europe, but it just shows that if you speak up, you use get your facts right, get your information right, and look who is the right person to bring that to, and don't go away, keep at it until, if it's not right, fix it. Don't be pushed away, find another route. If you get blocked at one avenue, take the next one alongside it. Just don't go away. And I don't mean be a pest. I don't mean, put yourself out there or be ignorant or arrogant with people. You don't have to be. If you've got the facts and you're right what you're saying, then just carry on until you've sorted it out. And if you get others to come in on it as well, which is what we did, we built up a body of evidence. So it wasn't just that one case. So it's then difficult for the other side to argue against and stick to the facts. So advocacy helps. Well, it certainly raises awareness, because for the example that Una gave you, it certainly raised awareness because within the press, the TV, the radio, everyone who didn't know about pulmonary fibrosis that was listening to the news did, and they all knew that they needed oxygen. It will influence policy, and it has influenced policy in the case that was mentioned. It reduces inequalities. It certainly amplifies the patient voice and the development of better care tools. So I was just going to say, John, there, Una shared a little example there of advocacy. Is there anything that you feel particularly proud of that you've achieved with advocacy?
Yes, but not alone.
No, of course.
I know that Norway is a privileged country with a privileged healthcare system. We get oxygen provided by the government. They pay for it. A couple of years ago, or 4 or 5 years ago, the situation was this, that oxygen for traveling, you have to pay that yourself and then get it reimbursed. And this could very easily amount to 2,000-3,000 euros for a normal holiday. So we started pounding on the government to say, you know what, this doesn't make sense. It doesn't used to be this way. You changed it, please change it back. And it took us 2 years, but we achieved it. So now the patient do not have to front that cost anymore.
That's a great example, John. Thanks for sharing. So, if we just move on to, sorry, before I do, is there any questions on what John or anyone like to raise? Yeah, we do, sorry.
Sorry. Yes. No, it is not a question. It is a quick comment, if I may,
Yeah.
as a clinician, which is important for what's been discussed already. It is so crucial and so important for the patients to be aware of what is quality consultation and quality care, and we have to make that seamlessly equal to all patients across Europe, because quite often the way the patients are treated sometimes it's a cultural approach. And we want to overcome cultural approach, and we want to overcome country standards. So quality consultation is patients' right. There is a standardized way how a quality consultation should take place, both from a patient perspective to be patient-centered, but also from a clinical perspective as well. All patient organizations should be aware of this standard, what that entails. And also it is very important, all patient organizations, if possible, to be aware what is their rights and access, not only to medication, it is not only the medication, but it's also access to social care.
Yes.
And many of the patients that live in different countries, they have huge variability across Europe to social care and benefits that should be receiving for their condition. And again, there are inconsistencies across countries, what different conditions are entitled to receive for their disease, and different to patients with interstitial lung disease, which is not known to many governments as a condition, and the disease barriers. So I have first-hand experience from patients' feedback that come from the country where I come from Greece, and patients who are literally really heavily disabled, and they still have to go to work when having, as I'm based in the UK professionally and work with patients in the UK, that wouldn't be the case, that these patients should have to fight for basic rights, that they are not possible to go to work with this disability, this level of disability. So these are things that, of course, patients' awareness and advocacy is so powerful and important, but also somehow this awareness to be streamlined, to be to reach to the patients' organizations the best way, so that they know how to fight for these essential rights.
Thank you for sharing that. And obviously something that the EUPFF needs to be looking at to ensure that patient organizations do fully understand their rights. Are we? Sorry, just right at the back as well. No. Steve. Steve over here.
I'm a patient, and in cooperation with my hospital and some of the staff, professors, we make some meetings, one every half year. And here we have newly diagnosed patients with IPF, and they come with their families. And I lead the meeting as a patient with support from the staff. And what we experience is that when the meeting is over, the newly diagnosed patients, they are relieved because they have been together with all patients, and they have a perspective of what the life as a patient can be. We also have online meetings. I lead it as a patient, and there we have from the whole of country in Denmark, and it's very valuable for the patients to have this opportunity. also for the relatives.
Yeah, I would encourage that, you know, to increase that as much as you can, to try and narrow the gaps from 6 months to, you know, as often as you possibly can, and ensure you also include those sort of meetings for carers and carers separately, as well as with patients, because carers do have different concerns. We have another question. Yeah. Steve, sorry.
Yeah, just a very quick one. I'm really benefiting enormously from the discussions now and the session before this morning. I mean, it's so easy to somehow, when you work in the way we do, to distance yourself from thinking about the realities in ways. But I wonder, when we talk about it, I quite agree, you've got to go out and find an alternative. If you don't get what you need, ask for it, challenge. It's extremely difficult. I know many people that come on, I speak to on the phone, patients who, very educated, very competent in their professional lives maybe, they still can't do it. There's a well-known doctor who may be in the room who found it very difficult to advocate for herself when she needed it. And I think we need to, somebody came up to me after one of the sessions the other day on navigating the system. I think we really need to be running training for caregivers on how to navigate, on how to ask, how to advocate for change, for getting what you need. I mean, we have a job to do as patient organizations in work. I mean, one person I helped recently, I just said, write a letter saying this, this, and this to the chief executive of the trust. And suddenly the whole world changed to that patient. Now, that patient was lucky to come to me on a Saturday night and get that advice, and it produced that. But what about the people who are less educated, who are poorer, who are leading more isolated lives? I don't think we're reaching them. And I really worry about that. I mean,
Yeah,
but I think, anyway, so a bit of a rambling statement, but anyway.
Yeah, just to come in there, Steve, very quickly, that's why I think we need our patient organisations to connect with their patients and their carers on a more frequent basis. And yes, you will have people who can speak out, you'll have others that don't. And if you can ensure that you don't need to train everyone, but if you can get some leaders within those organisations trained up and directed. Sorry, Chantal.
It's okay. Just I want to go back to what John said about carers, and well, the idea that really carers and patients are a team. That is something that should be ingrained in every mind. And when you have an appointment with a physician, this is really something that has to get through, that the physician should also listen to the carer and maybe occasionally ask the carer how he or she is doing. That might be nice as well. But basically, the carer has this experience of living 24/7 with the patient. And so this brings in interesting information, I believe, into the conversation with the doctor. And one, maybe if I can call it an advice, is if you're a carer, be persistent, maybe even a little bit boring, but never stop asking questions.
Okay, John?
Yeah, just going to make a call to action
Yeah.
and say equal rights for carers, okay? Because carers matters, carers knows, and their voice should be heard. Thank you.
Thank you very much, John. Just very quickly, I'm on an orange, so just very quickly, what I would say is core components for a gold standard of care, and we'll finish on this note unless there's any questions. Equitable access to treatment and clinical trials, I talk about for everyone, for every patient. Early referral to ILD centres and to healthcare professionals. Multidisciplinary team approach, and I think it was mentioned today about ensuring that within that multidisciplinary approach is that we have a psychologist, somebody who can help the patient as well on that. A routine shared decision making. You need to talk to the patients routinely at those meetings, make sure that where you're at with their care is where they want to be. It's not where you want them to be, it's where you all want to be. integrated psychological and social support, care inclusion. You know, Chantel and I have been, and Maxine's not here, we pushed about that yesterday. John's mentioned it there. We are very, very important, I can assure you, and please talk to us, find out about your patients and use our expertise. We do develop quite a lot of expertise. Transparent communication, yeah, let us know what is actually going on. Continually review, and an honest dialogue. So, I'm going to just go through these couple. My visions towards a patient charter would be future gold standards should include outcomes that matters to patient, early supportive and palliative care, digital and remote support, standardized minimum care pathways. So a patient charter should be creating clarity, equity, and accountability. Takeaway keys, shared decision making, I believe we talked today, I'm sure we all agree is essential. Advocacy will drive improvement, and it's certainly got a reaction in the room today. A patient charter can provide a roadmap, and gold standard care means partnership, not hierarchy. Patients are not just recipients of care. They're partners in creating better care. It's not the final one. The human reality is that patients do face breathlessness, fatigue, uncertainty in their future. Carers step into roles that they never expected to. Clinicians manage complexity while navigating limited systems. So, if we truly listen, if we truly share decisions, if we truly commit to partnership, then we move from treating the disease to caring for a person. Thank you very much. And no red card. Thank you, everyone.
Yes, we have a question. Is it
Oh, sorry, my apologies.
Sorry, I don't want to overrun. I mean, I very strongly agree with many of the points that you've raised. But I want to highlight that we need to be encompassing all patients and their families. And just to give you an example, I look after over 2,500 patients in the ILD service in Cambridge. Mm-hmm. Patients who go to our support group, there's about 50. Mm-hmm. So that means, if you do the maths, you know, over 90% of our patients aren't attending a support group, aren't getting all of this information. Mm-hmm. So we need to have a way that we can encompass that and be inclusive and address these inequalities. And I think it's really important that there is some information, either toolkits or some advice. It needs to be in lots of different formats because not everybody uses computers, so that we can actually make sure that patients know all of the opportunities that are available to them from the beginning or as early as we can in their journey.
Could I just share what we do? Now, I do realise that I come from a very small country, so I probably know all of my ILD, well, I do know all of my ILD nurses in the country. I know the bulk of all of my consultants, and I know a lot of my patients as well that have pulmonary fibrosis in their carers. What we actually decided to do was to ensure that we had, for a start, information that whenever patients arrived at the hospital, we would have within the ILD consultants and the consultancy rooms, we will have a poster up basically saying pulmonary fibrosis NI and a QR code that they can quickly scan on their phone, takes them to your website, tells them what's available. But what is also given to them, we also provide a booklet pack. And within the booklet pack, there'll be a booklet on breathlessness, there'll be on psychological impact, antifibrotic drugs. Now, the ILD nurse can either give them the full pack, you know, it'll include oxygen, everything else, or they can give them what they need at the time. And we've taken all the jargon out, so it's, and again, within that. And it also points out quite a lot of information on, like within the UK, you can claim back electricity for your, and we give them, for their concentrator. All that sort of information is provided at that stage. So they have, and what will happen is that if a patient says to Pat, for example, I'm interested in what's going on within this support group, and the ILD nurses will mention it to them as well, they will get my contact number, and all that they will contact me, or I'm given one contact for them, i.e. with their permission, let's say an email address. I then contact them, and then we can have a chat about what's provided. We also ensure that we have communication tools like WhatsApp groups. They work very well for patients to ask questions of one another on carers, because we would have WhatsApp groups for our patients, separate one for our carers, separate one for our bereaved family members, because we look after them as well. And because we're smaller, I think it's easier to do, but I think if you start there and people know there's support straight away, and if you can get the ILD nurses, who are always the ones that they want to talk to, they're kind of a bit softer to go in and speak to, prepared to let them know what's available. I mean, you've got very good charities, yourselves around you. You've got Action for Pulmonary Fibrosis Trust, and even if they want to come and sit in on our support group meetings, we have people from all over the place that sit on it, because we hold one every Tuesday morning, come from everywhere to listen in the group. Because as was said at the back of the room, all patients are hungry for information, and they're hungry for information not just from clinicians, they're hungry for information from fellow patients who have been there and wore the T-shirt. And they lots of tips and advice that can be shared with them that's not given by clinicians. So that's just one example of what we do. Thank you, Alba. Yeah, I'm in trouble. If Alba turns up, it's worse than a red card. Thanks, Alba.